necessarily itself surveillance, but it's hugely linked into the surveillance work we do. So we will go on to talk about that a little bit later. But surveillance is something that's a little bit it can feel a bit above our heads. It's kind of something that goes on. It's often routine work, and it's just you're never quite sure who's using all the data that we might be collecting. So this presentation will hopefully give us a little bit more context around how we use surveillance. Sorry, there's just a few microphones on at the moment. If you could all mute your microphones.
Yeah, I work for public health. Basically, it's about lifestyle improvement. So basically, we do all the well-being of.
Thank you. What is surveillance? It's collection of health information for health action, and I think that's just the really key point, is that this is all information we're meant to use. It's not research. It's about trying to work out how things work. It's about taking some form of action on the basis of the information that we're collecting. So that should always be at the forefront of our minds with any of the data that we're collecting. And it's really important when people are actually designing surveillance systems that they have some actions in mind, but more importantly, that they know who is going to be using this kind of data, that they've spoken to those people so that we actually know that it's fit for purpose in terms of the information that's collected. So health action is always a thing to bear in mind, that there's got to be an action at the other end of it. This is cases in Sandwell. So for every day since March the 13th, this plots the number of positive tests of people who live in Sandwell in the past 7 days. Using 7 days because you get, sorry. Oh dear. I'm sure it's not COVID. So that's past 7 days just to even out the weekend effect. But even with that, you can see that it's very uneven, lots of up and down, lots of changing directions. And this is our best source of knowing how many people in Sandwell actually have COVID-19. But if we look straight away to, for example, in April, we've got this dual peak. Why is that going on? Is it because cases went down and went back up? Or are there other things going on with our surveillance system? Similarly, again, over the past month and a half, we've seen rising cases, but there's these dual peaks. Is that because we were successful at first and then things started dropping off? Or are there other things going on? Just how much can we rely on like a straight reading of these figures to say what's going on? Because if we think back to April, you couldn't get a test for love nor money. So it was really, really difficult back then to actually try and get a test for COVID-19 until about mid to late April, when we really started gearing up the testing. And you'll remember Matt Hancock's 100,000 tests a day promise by the end of April. So towards the middle of April, what we're seeing rising case numbers, but that doesn't actually mean that there's a rising number of infections. And in fact, the truth is probably the complete opposite, because we went into lockdown on the 23rd. So as with all data, knowing more of the story of what it is we're measuring, knowing what else is going on, as well as the actual system of collecting that data is really important to actually be able to infer from the data and work out what's going on. And having that having expert knowledge from other people to draw on is crucial to helping us interpret these sorts of graphs. But the main thing I want to get across here is that surveillance systems are actually really difficult to get right, and that we really need to know a lot about how the data is collected as well, and what it is we're even collecting. What does this graph, what's the data it's actually collecting, tell us? So the first thing I want to raise there is with the surveillance iceberg, this idea that actually the number of tests we've got only tells us a fraction of what's going on. That what we get is a report. That's what we're actually told. These are the reported cases that we get. But many of those cases, do we get 100% of positive samples in the lab come to us to be reported, or are there possibly issues once the test is actually done in getting that to the report? And actually, even in the past week, as we've gone live with our contact tracing on the national system last Wednesday, at the same time there were major issues in the labs, which meant that we weren't getting the data flowing to us. And so even though somebody knows about those positive cases, we don't know, and we're the ones taking action on the basis of those cases. So it's, again, that's why this whole thing has to be oriented around action. It's not enough that somebody knows, but we need to get the right people to know about the positive cases. And then of course, in terms of actually getting the positive case, we need to have taken a sample, which means someone needs to have actually sought out a test or sought medical attention, which means usually they need to have been symptomatic, which means they need to have been infected. And, all of these things, we're only going to get a fraction of those people. Maybe only 40% of people are symptomatic, or 20%, nobody really knows. So there's all these issues when we look at this graph. What proportion of infected people does it actually represent? How much can we, and is that proportion going to be consistent over time? Those are really important questions when we're trying to work out what's the trend. Are things getting better or worse? So that should be surveillance systems. Looking at how do we actually develop that system? What should the system do? And the first question we can ask there is what are we collecting? What's the kind of unit of collection that we're looking at? Are we just going to look at test results and diagnoses, or do we need to know other things? Do we need to know about exposures and behaviors? Do we need to know about people self-isolating? Do we need to know about how many people are going into work? How many children are in schools? These sorts of questions can help us. Those aren't necessarily the main thing we're looking for. The main thing we might want to know is test results, but the surveillance system has to be wider and tell us about those other related things, so that we can tell if should we expect results to be going up or down? Are there other things going on? And why are infections rising or falling? And this is, for COVID-19, things are perhaps more straightforward than other surveillance systems. But if we're thinking about another infectious disease like STIs, we might want to know about people's sexual behavior, so that we can understand why rates might be going up or down, or whether we should expect rates to be higher than they are, and therefore we might be missing lots of tests. We need to think about who is it that we're actually defining as this would be our case definition, at the time, the place, and the person who counts as a case. In the very early days of pandemic, back in February, our case definition was narrow. It was related to travel quite often. Are people symptomatic? Have they recently traveled from another country? And was that in the past 2 weeks? So basically that person had to have been in a particular place and at a particular time in order for them to have been exposed to COVID-19. And so we needed to have a rigorous case definition. But then what we know with the majority, the infection strain that we have in the UK, is that actually it's probably traveled through Europe to get to the UK. And that's the strain that forms the majority of infections in the UK. It's not one that necessarily traveled through, it's not a traveller from China to the UK. It's a traveller a traveller came from somewhere in East Asia. They would have gone to somewhere in Europe, and then in Europe it spread, and then it came to the UK. That's the one that's the kind of lineage of the dominant strain. So even though we had this case definition, it might have excluded what ultimately became the main kind of source of infections. And so we need to be quite careful about what case definition we use. Who is it that we actually include and say we're interested in? And that needs to be clearly defined. So with our Sandwell example, again, we've got cases in the past week in Sandwell who tested positive with COVID-19. That's our time, place, and person. And how do we look for it? What is the mechanism for the surveillance system? Is it going to be passive or active? Passive or active will refer to is it something that's collected on a registry? Is it something that we do routinely all the time? Or are we actually going out specially to look for it? So, for example, a passive surveillance system might be people going into hospital who need a COVID-19 test as part of their treatment, and that COVID-19 test result then gets passed on to public health. But an active system is like what we're doing at the moment in Sandwell, where we've got lots of local testing sites, walk-ins and drive-ins, that we're asking people specifically, can you go and get tested if you've got any symptoms at all? Because we need to know if people have got COVID-19, not just so that we can treat that individual person, but so that we can act on the population as a whole. And so that's active surveillance. And then there's other forms as well, sentinel surveillance. So, for example, we might ask specific GPs to, for a flu season, we'd ask them to swab every single person who came in. And we wouldn't do that in every single GP practice. We'd only do it in a narrow few GP practices because we don't have the resources to test everyone. So this forms a sample for us that everyone who comes into that GP practice with flu-like symptoms would get a flu swab. Enhanced testing might be a sort of short-term increase in testing in some form. So again, the what we're doing in Sandwell at the moment, where we've additional local testing sites in place, that's not intended to be long-term. That's not going to be around forever, but while we've got this spike going, and we've got such a large number of people in Sandwell who don't have access to a car and can't go to a drive-through, we need to have walk-in sites in order to get a proper sense of how many people are actually infected in Sandwell. And finally, there's syndromics as well, where instead of looking at a test or a particular or some kind of definition, with syndromics, a syndrome is a collection of symptoms, and so, for example, where people are going into a GP surgery or an A&E, they might not necessarily have a test or anything that they can confirm what's going on, but they can still take a guess at what the diagnosis might be, whether it might be food poisoning or flu again. And we can collect that kind of data to get an ongoing sense of how many people have been are coming in with that collection of symptoms. And that collection of symptoms, if you look again to our surveillance iceberg, symptoms is much earlier on in the chain. So even though looking at symptoms might be a lot less accurate, it's firstly earlier, it can happen quicker, and it will capture a wider group of people. So that can be really useful for something like flu, where we're anxiously awaiting the flu season every year, and you can use syndromics to try and just get another week or two's lead time on when we think flu season starts. So how can we use these test results? There's a huge, a surveillance system rather than test results. There's a very wide range of possible uses for surveillance systems, and so you don't necessarily have to define one particular action that's going to be taken on the basis of surveillance data, but that it often has to be kind of agreed with all the other organizations who might be using that particular surveillance system that might be acting on them. Is it likely to change any actions if they know how many people might have a particular condition? So some of the key uses we might have are just estimating just how big a problem is this, because that can form commissioning decisions, and how many resources do we put into this. Understanding the natural history of a disease or injury, knowing what happens to someone after they get the event. How long does it take someone to recover from COVID-19, going into ICU, becoming severely unwell? Do they then need lots of other care and support after they've recovered. Obviously, detecting outbreaks and epidemics will be important, but also knowing the distribution and spread that fits in. So, you know, we know in Sandwell we've got rising case numbers, but where are those case numbers happening, and who are they affecting in particular? Because that can again target the way we might try and respond to the outbreak. We also might want to know, how is it spreading? Is it spreading in offices or on public transport? Is what we're doing working? Are there any changes to how the infection is working? Have we suddenly had an increase in the number of people getting severely unwell? And we might want to know whether people are actually isolating following case confirmation. So when we tell people you have tested positive, do they actually isolate? Do their friends and family who they've been in contact with also isolate, or do they actually go back into work? And do we need to act on that as well? So that might raise the question of that again. You know, if we don't necessarily know how other people are going to use this data, should we bother? Is it worth the huge effort and expense that goes into setting up surveillance systems? And with COVID-19 test and trace, obviously it combines the trace function as well, but the testing, which was that earlier first part of it, that's been £10 billion, hugely expensive to set up that much surveillance across the entire country. Why would we bother in this case and not in other ones? Here are some really classic criteria for what might why you might choose to set up a surveillance system for a particular disease. Frequency that's sort of fairly obvious, but the more of it you've got, the more you need to know where it is and how much of it is happening. But severity is really the key one. That's what makes COVID-19 so different. We've had so many more deaths, from 60,000 deaths in just a couple of months. From flu, we normally have a maximum of 40,000 deaths, but you know, this is 60,000 deaths was with all our lockdown and with all these other huge preventative measures, so the frequency of it was reduced than it otherwise would have been. So you know, that's what really separates it in this case. But we also have to think about the cost of that surveillance system, whether the disease is preventable. Is there actually any use again to surveilling people? Is there anything we can act and anything we can do on it? Can we communicate those results to people who can act on them? Sometimes a positive case is quite an easy piece of data to communicate, but syndromic surveillance, for example, where you've got a range of different symptoms, can be more complicated and more difficult and more nuanced to try and communicate it. And finally, public interest, of whether actually there is some increased public interest in that particular disease, if there's some reason that the public might be interested in knowing what's going on. So once we've thought about what and how we're going to look for, how we bring that together, as we've seen earlier on in that iceberg of surveillance, there are so many different steps along the way that can go wrong, that it's really important that surveillance is thought of as systems, that it's not just about a single test, but that we have to have everything in place and working together. But we've got that, firstly, the clear objectives of what we actually want to achieve with this surveillance system. And then that's supported by the case definition. Are we actually looking for the people that we need to in order to support those objectives? Have we decided how we're going to collect it? Are we using enhanced surveillance? Are we bringing in local testing sites? Are the methods tested? Do we know how well the swabs work? We know that the swabs very rarely have false positives. So if the swab is positive, it's very unlikely to be wrong. But if the swab is negative, sometimes there's a higher chance that it's missed a case. And so we need to be aware of actually how limited this can be, that our positive tests are likely to be an underestimate just because the swabbing itself is a flawed process. Then we need to work out what are we going to do with the data? How do we analyze it? How do we know if cases are going up or down? How can we be confident with that? Who do we share it with? And how do they act on it? And all of these things should be in place before we start looking at the surveillance system, at collecting that information and working out whether we implement it and work through all of that. So we'll look a little closer at a few examples of that, and the first one we'll talk about will be the NOIDs, the notifications of infectious diseases, and that's a legal duty that all doctors have to notify public health if they make a diagnosis of a particular list of diseases. So I've included some of those from the past week. This is for the entire country, that we can see different notifications of infectious diseases that have come from medical practitioners. Things like hepatitis, COVID-19, malaria, tuberculosis. And you might notice that there aren't very many cases of COVID-19, that it's outweighed by food poisoning and other, which can be a wide range of different infections. And this is because the NOIDs, these are what's coming to doctors. And at the moment, anyone who's got COVID-19 symptoms, instead of going to a doctor, should be going for a test first. It's only if they become severely unwell that they go into hospital. And in general, they shouldn't necessarily be going to a GP practice until they've had a test first, if they've got symptoms of COVID-19. So it's even though you might expect COVID-19 detection to be higher in GP or in hospitals, it's actually kind of being supplanted by other surveillance systems which are taking the place there. So all these notifications of infectious diseases, they go to public health protection teams, who then work up that particular situation. So, for example, if there's a suspected food poisoning, they might go and investigate it as an outbreak to find where it came from and if there's a risk of it happening again. And so that's a part. This notification of infectious disease, it's a routine surveillance system, but it can lead to investigations and sort of heightened surveillance within a particular outbreak setting, where if we think that there's COVID-19 in a care home, if we detect one case routinely, we might go in and swab everyone, and then that would be enhanced surveillance. So there are lots of different ways that this ends up working as part of a surveillance system, and there can be an enormous amount of work into planning it out, making sure that it's working together, but it's pulling it together, that we're not testing just for testing's sake, but that we have the systems in place to take all the action that we need to as well, which can often include further surveillance. This is the Royal College of General Practitioners Sentinel scheme. So you can see on the left, this map, the red dots are all the GP practices that are part of the Sentinel scheme. There's not enormous numbers of GP practices, and every year 100 of them will be asked to do flu surveillance. So they will swab everyone who comes in that they suspect has got flu. That goes off to be tested, and that gives us positive case identification of all of those suspected cases. So we, instead of having just a suspected or probable case, we can actually have a confirmed case with the Sentinel schemes. And then that works in tandem with something like the real-time syndromic surveillance, who capture all of that, all of those symptoms that that GPs and NHS 111 and emergency departments might be collecting, and tally them up and look for any changes and trends. So these two graphs here, for example, show what happened when we started when the pandemic began. So on the left, you've got looking at COVID-19 like illness from the beginning of March. You can see that spike, which peaked at the beginning of April, about 2 weeks after lockdown, which was exactly what we expected. Unlike the Sandwell graph that I showed you earlier on, where we had that dual peak, one at the beginning of April, which was probably the real peak in infections, and then a later peak, which was due to the increase in testing. And then also very interesting to see is people coming to emergency departments with heart attacks in the same period. And you can see that the number of presentations to emergency departments for heart attacks halved. It's gone from around 200 to nearly 100 over that time period. So people stopped turning up if they were having heart attacks, they just stopped coming to emergency departments. So that was, and there we can work through what's causing this change in the data. Is it some change in recording? Well, there's no reason to think that emergency departments stopped telling us about heart attacks. People stopped turning up. That does appear to be the case. Is it because heart attacks weren't happening? That's very unlikely. You can see that the rest of the time, heart attack numbers are very consistent. That they don't tend to vary much, and it's not something you'd see a typical variation around then. So what we can take from that is that COVID-19 caused people to stop going to emergency departments, even though they were still having heart attacks. So why did it cause people to stop going? Is it because they were scared of catching COVID-19? Is it because they didn't want to use up emergency department resources? Is it because we told them to stop coming? Because we close emergency departments and say that you can't come in here for this thing? And it takes a lot more, even though we can say this with good confidence that heart attack presentations dropped, we still need a lot more other data sources and surveillance to say why that happened. And that's why it's really important, as I was saying earlier, that we've got this indicator, we've got this disease diagnosis that we're looking at, but we also need to collect other things around behaviors and exposures and other questions like that in order to understand what action we need to take. And also when we're looking at this data, before we assume that there's an actual result, we need to work through and see if there's other causes of changes and trends. So as I was saying with that Sandwell graph with the 2 peaks at the start, is there some artifact of the data? Was there something to do with the data that meant that we had a second peak at the end of April? And yes, it was, because there we had more testing coming in. But also what can happen sometimes is that you get the test results on a certain day. It's not just that the test is done maybe 7 days a week, but maybe they're only processed a few days a week, Monday to Friday perhaps, which would make it look like we're getting lots of results Monday to Friday, but fewer results on Saturday and Sunday. It's not because fewer tests or fewer exposures or infections are happening then. It's just the way we report it. So we need to always look for explanations there. But then we can also think whether it's just random chance. You can see, looking at the syndromic surveillance again, that this black line is an average, but the green lines are the actual figures. It's going up and down all the time. So how do we know actually if the changes are really due to some increase or decrease, or if it's just random chance? Is our data picking up some kind of bias? For example, if we're looking at syndromic surveillance and we were looking at influenza-like illness, where we're trying to say, when does flu season starts? What if we just had a lot more colds or something around then, and people were misdiagnosing that as flu? That could bias our data to say that that flu season started earlier, when really people weren't actually getting flu, because it's not high quality data. It's quite biased. So those are all things that we can think about before we actually assume it's an actual result. So finally, let's look at our COVID-19 surveillance system. So this is the national testing strategy from April. There were 5 pillars to testing and to surveillance for COVID-19. The first 2 were NHS and commercial swabbing. So initially, all of the swabbing, and when they say NHS, they are including Public Health England, but of course, NHS has got a stronger brand, so a lot of things get included under that. The swabbing was initially all NHS, but the peak capacity with the NHS and the Public Health England swabbing was around 2,000 a day. So that was in around March time. So they really hit a bottleneck for being able to test enough people. When we brought on that was expanding as well, but it's the commercial swabbing and particularly the Lighthouse laboratories that has really expanded our ability to test. And now the majority of tests done are commercial. The commercial tests they include the local testing sites, the drive-throughs and the walk-in centres. They include the home test kits that get sent out. But then our proactive swabbing, when we go into a care home, for example, to swab everyone, or when we arrange for someone to go into a workplace to swab everyone, that's arranged through the NHS. We pay the NHS to go and do those, and the testing is done through the NHS. There are different routes coming in that might affect what happens with that data. For example, the commercial, as we saw at the end of I can't remember when it was, when they inflated the numbers by sending out a lot of test kits and including test kits that had been sent out but may never have arrived or never been used or anything like that. So there were. It's important to kind of see those, to be aware that those are separate at times. We also have the antibody swabbing. That's totally different to testing for positive cases. Antibody swabbing can give us an idea of how many people have had it. And the Office for National Statistics has been heavily involved in doing that, in doing prevalence studies. And they think now that around 6% of people have had COVID-19 in the UK. And finally, the surveillance testing, which is again, that fits in with the Sentinel testing, where there are specific sites that we might be testing at. For example, with blood donations, which we've been testing for some time to try and get a sense of how many people might be asymptomatic carriers. Blood donors, they aren't necessarily representative of the general population, but they do have, they're volunteers who come in who should be fit and well, who shouldn't have symptoms. So and they've already provided a sample. So you've already got a blood sample there that you can test. So it's a convenient, routinely collected sample that we can look at to try and keep an eye on what's going on in the general community when we look away from people who've got symptoms. This diagram, I won't go through it in depth, but it just shows what actually happens to Pillar 1 and Pillar 2, as well as the other 2 pillars, but specifically Pillar 1 and Pillar 2 which have all of our case data. And you can see that Pillar 2 tests that are sent out are counted as made available, whereas whether they're actually processed, that's all at the lab level. So really most of the data that we look at is based on what's actually going on at the lab, and what makes it to the lab. So once again, coming back to our graph of cases over the past 7 days in Sandwell, we've got the actual peak here, and then we've got this maybe false peak here. And the same thing has happened again here, that over the past month, when we had this spike at the end of July, it seemed to go down and then it went back up again. But we have to remember that towards the end of July, we started bringing on board lots more testing in terms of the local testing sites. We brought out our communication strategies to really make Sandwell aware of everything that was going on. So where we've got this peak here, was that actually due to the increased number of testing that was being done around then? Had these cases actually been going on for a month before that, and where we've got this end of June quiet time, was that actually a lull in our activity, but not in the virus spread? One way of looking at this is looking at positive test rates. So how many, what proportion of COVID-19 tests turned out to be positive? And again, you can see that at the beginning of April, over 30% of the tests that we did were positive. So that correlates with this peak at the beginning of April. As it's going down, it declines very sharply towards the end of April, so that by the time 30th of April, we're down to below 10% of tests being positive. That's partly due to the numbers of cases going down, but also the number of tests going up. And we can see that the test numbers have stayed very, very low, but also consistently a very low proportion as being positive. So where we might see national statistics saying that the numbers of cases are rising, it's very hard to say that that's due to increasing testing or anything like that, because our positive test rate is still very, very low. So we're still, even if we do increase the number of tests we're doing, if the numbers of tests that are positive stays similar or sort of in the same magnitude, you can't say that we're just detecting cases that we weren't previously detecting, because if that was the case, you might expect our positive test rate to go down. It's also worth thinking about other things that we're surveying in terms of COVID-19. We've talked about positive cases, but we should also think about outbreaks. How many individual settings are there where we get multiple people being testing positive? As I mentioned last week, COVID-19 as an infectious disease is very prone to having these very high risk, high reward outbreaks that most people don't infect anyone, but then you get some infections which cause a lot of infections. So we can look at those events as well, those outbreak events where we get multiple transmissions linked to one particular time, place, and person. And finally, the clearest example that we're acting on this now is with our contact tracing. So every single case that is detected gets contact traced. We talk to the cases and we ask them to isolate as well. And we can actually do routine surveillance on the contacts of positive cases, so that we're looking at how many of them might turn out to be positive, how many of them are linked to particular outbreaks, and all sorts of other useful health surveillance information that will tell us what's going on with COVID-19, how is it spreading, how can we manage it, how can we act on the epidemic. So that is both the end of this presentation and I think the end of the programme. Does anyone have any questions? Ali?
Yeah, Neil, just wanted to check, the contact tracing. Are we doing for every single case, or are we just focusing on the ones that they failed to contact them nationally? Just wanted to check that. And are we doing contact of the contacts here?
So, no, to your second question, and that's a bit more straightforward to answer. We aren't tracing. So, just to make some definitions clear, the case is the person who has the disease, and the contact is someone who is at risk of getting the disease from the case. So let me just bring up these slides. There we go. So we've got the case that has tested positive. At the moment, we are contacting everyone who has tested positive. And there's duplication there between what we do and what the national system does. But with everyone who tests positive, we aren't actually contact tracing them. We're only speaking to the case themselves, make sure they've got the advice. And also to ask them about this backwards contact tracing. We're looking for the clusters that people have come from. So our surveillance is more focused on the backwards tracing rather than the more famous forwards contact tracing, where you look at who's at risk of exposure and asking them to isolate to make sure they don't spread it to anyone else. So at the moment, everyone in Sandwell we contact to ask for cases, but we know that at some point soon, the national system is going to start taking on the cluster tracing function as well, that backwards tracing, at which point we will stop contacting everyone and we will only contact the hard to reach people, the cases who the national system have failed to reach within 24 hours. So they might be people who don't have contact details, who don't have any case details, or any who haven't answered the phone, or who might have language difficulties that the national system hasn't managed to overcome. Does that answer your question?
Yes, thank you.
Good. Diane.
Similar to Ali's question, really, and a bit of a follow-on. So, so in one particular case where we've been contact tracing, so we knew of a setting that had a positive case, and then we proactively contacted people because we got the contact list for that setting. We contacted people who'd been to that setting. Yeah. Just said, we gave them the standard advice, symptoms, test, and all the rest of it. So is our system set up so that if we know that we've contacted someone to say, you were at this setting on this date, there was a positive case of COVID there, can you isolate for 14 days?
Yep.
If then we get a positive test come through for that person, does our system match those two up so we know that they were in that place?
So that's where it becomes routine. The short answer is routinely no.
Right.
But if we're managing an outbreak in a setting, we will usually be paying more manual attention to that. So if we've arranged testing, etc., we will try to link those people. In the systems that we've got at Sandwell, they're not as advanced as something like Health Protection Zone, which is what the health protection teams use. I believe that HP Zone does, if you've got a contact who is linked to a setting and that contact gets a positive test result, I believe that is linked automatically, so they can do the epi work. But in general, this isn't something that can be automated, and you need the field epidemiology teams within Public Health England, or whatever it is after today's announcement. They'll do that kind of more in-depth work of tracing how many infections has this outbreak caused.
Thanks, Neil.
You're welcome. Any other questions? Nope. Okay, we've finished a little bit earlier today. Obviously, feel free to email any questions you do have, and this session has been recorded, so it will go online. I hope that you found the whole series useful, and that it's helped you to start to engage a lot more with everything that's going on. Obviously,